I'm going to talk about is the potential implications for second-line ARVs, following a trial called NADIA and a few other ones, which I'll just really briefly touch on around that too. And what's happened really is that I think these trials, NADIA and others, have really changed what we view as a second line, and really made it in some ways a lot simpler in terms of how to manage patients. And I should just be clear that the HIV Clinician Society has already taken a view on this and has moved ahead. The Department of Health hasn't yet, but is expected to, my understanding is, fairly soon. So that's the kind of context that we're playing in. So I'm going to outline what we currently do, and then some of the three main trials that inform why we think we should be doing something a bit different, and then what we currently recommend. So it's just worth reminding ourselves of the current paradigm. This is starting with efavirenz. Now I know we mostly start with dolutegravir now, but what about if you started with efavirenz? You're on tenofovir, emtricitabine, efavirenz, TEE. They start off in green, they're susceptible. Over some time, they develop virological failure, though, the patient. And then they have, let's say, high-level resistance to emtricitabine, high-level resistance to efavirenz, and with or without high-level resistance to tenofovir. That's about 50-50 with tenofovir, whereas the other two are about 90% likely to be resistant when you fail them. So in that scenario, what have we traditionally recommended? Well, we've said switch to second line, and what we're going to do in that case is switch out the efavirenz to dolutegravir, so totally new drug there, new class. Switch out the tenofovir to AZT, and the reason for that is that AZT you could guarantee would be susceptible, regardless of whether or not there was resistance to tenofovir or emtricitabine. You knew that AZT was likely to be susceptible, in fact, maybe hypersusceptible, depending on the mutations that were involved. And then we always knew we could continue the 3TC or the emtricitabine. So 3TC and emtricitabine we used interchangeably, and despite the fact that there's high-level resistance, we knew we could reuse it in the second line. And that's interesting, but it's worth just pausing and reminding ourselves of that fact. Remember that in the previous slide, I'm just going to go back just to show it to you one more time, that we never change just one drug in a failing regimen idea. So for example, here in this failing regimen, we're going to change at least two, change the efavirenz and the tenofovir out, and then we'll just leave this 3TC on. So you've got this never change just one drug in a failing regimen dogma. That's what we were following at that point. And we were always happy, like I said, to reuse the emtricitabine or the 3TC. Why was that? And this is worth just pausing just for a second on, because I think it explains potentially a lot of the other changes that have happened. So we know we could reuse 3TC or FTC because the mutation almost always was what's called this M184V mutation. What does that mean? It means at the 184th codon, which is really just every 3 bases of the genome, the methionine was changed to valine, M to a V. So that was the mutation. And this particular mutation is almost always the cause of resistance to 3TC or FTC. What does it do, though? Well, it causes high-level resistance to 3TC and FTC, fine. But it also causes a bit of low-level resistance to abacavir. But interestingly, it doesn't affect tenofovir or stavudine for what it's worth, and it actually causes hypersusceptibility of AZT. So the AZT becomes even more susceptible, and in fact, that applies to tenofovir and T4T as well. And this is the key point, though, that we know that even in the face of this mutation, this 3TC type mutation, we know that the virus that is able to survive that is so-called crippled. The viral load declines by about half a log, which is about kind of 2/3. So if you're at 100,000, maybe it's roughly 30,000, just with this mutation, despite having this mutation. So what does that mean? Sorry, it's jumping around a little bit. We understand that basically we can continue to use 3TC or FTC in the second line and third line regimens despite high level resistance, because it retains activity. So that's really the bottom line. If we look at it over here, despite this mutation, it still retains activity, so you can still use it. And we know this because we've been doing this for years. In second line and third line, we still use it. It's not useless even though it's resistant. Even though there's a resistant mutation, it retains activity. So it's not totally resistant. It's got some activity. That's the scene I want to set, because now let's look what happens to tenofovir. Tenofovir has a similar type of mutation. It's called K65R for whatever it's worth. Don't need to necessarily know that unless you're in the field. But again, it also causes about a half log decline in viral load. So what that means again is that despite having a mutation that we think in past years and just knocked out any effect of this drug, of tenofovir. In fact, even in the face of that mutation, you don't lose full activity. You still get quite a lot of activity action from this drug, despite getting resistant. So if it's susceptible, it's got full activity. If it's resistant, so to speak, it's got quite a lot of activity still. That's the same thing we saw with 3TC. And the fact is, we're seeing it now. Well, we've known about this for decades with tenofovir too. So we happily reused 3TC, but we never really thought to reuse tenofovir again, at least before it had been proven to. So until Nick Payton and his group from the NADIA trial decided to test that. So let's just talk a little bit about the trial itself, because it's really helpful to know what it did and didn't show. They took people who were 12 years or older, and who were on an NNRTI-based regimen, so either efavirenz or nevirapine, along with tenofovir and 3TC FTC. So like, for example, our TEE regimen that we've been starting on patients on for years until the last year or so. If they'd been on for more than 6 months and they were failing, they had a viral load of more than 1,000 copies, they were able to be enrolled in the study. So again, think about, just worth reinforcing, it's people on regimens like TEE. So these are not dolutegravir-based regimens. These are NNRTI-based regimens, so efavirenz or nevirapine. And also tenofovir. And if you were on those regimens and you were failing for more than 6 months, you could be enrolled. They didn't enroll people with pregnancy. They didn't enroll people with kidney disease because of the tenofovir. And you couldn't have had previous PIs or integrase inhibitors either. Excuse me. So that's who they enrolled. They took people from Uganda, Kenya, and Zimbabwe in this case. So it was done in Africa, which is really good, because we've realized over many years that you really have to do these trials in local settings, at least in sub-Saharan African settings, to understand how it's going to play out in some of the biggest markets for HIV in the world. There were about 464 people who were enrolled in the end. And they did this complicated thing called a factorial design. But basically, they were trying to answer 2 questions separately and simultaneously. The first one was, could you switch to dolutegravir-based regimen or darunavir-based regimen? That's interesting, but I'm going to park that issue a little bit for now, and we'll come back to it a bit later. But really, the interesting thing here is, should you change to AZT in second line, or could you just continue your tenofovir? And because it's randomized both ways, you could have, say, tenofovir and either dolutegravir or darunavir, or AZT and either dolutegravir or darunavir. So you were randomized this way and you're randomized that way, and then you got 3TC or FTC added to it, whatever you had. So you can see there are effectively 4 different options here. Obviously, if you had Hep B, they would still add the tenofovir, at least in this case. But so again, I think the key thing to focus on is this one here. Tenofovir versus AZT. And remember, these people had been on tenofovir and failed it. So the trial was asking, could you continue tenofovir, or do you have to switch to AZT? That was the one question. The second question was, is dolutegravir as good as darunavir? What were they looking at? Well, they were looking at people, in other words, who were virally suppressed, and they defined that as less than 400 copies after about a year. And then they looked at some other things too. They looked at people under 1,000 copies, because that's what WHO and Department of Health still recommend. They looked at mutations that developed over the time and CD4 as well. And then the so-called non-inferiority trials. So they weren't able to show, well, they weren't aiming to show it was the same or superior. They're really just aiming to say, is any one of these options inferior to the other? Okay. So again, just worth reminding ourselves, these are people on efavirenz-based or nevirapine-based therapy with tenofovir as first-line therapy. If they're failing, they were able to be enrolled in either, for the tenofovir side, either continue or switch to AZT, and for the efavirenz component, either switch to dolutegravir or switch to darunavir. So that's the trial. What did they find? Well, here's what they looked at in the first question, dolutegravir versus darunavir. This is what's called a forest plot. For those of you who don't know, it's a nice graphical way of seeing which is better or worse. So basically, this, if on the line here of 0 is no difference. So, and then anything to the left of it was darunavir was better. Anything to the right of it, dolutegravir is better. These dots are the point estimate. So that's what the number came out as in the trial. And then there's a 95% confidence interval on either side, which just shows really that you could be 95% sure if you ran the trial again that the true result would be somewhere between here and here. So you can see we're really looking at these from here to there. And if you look at, for example, the population as a whole, you can see darunavir, the point estimate a little bit better, but effectively when you look at this whole interval here, it didn't really show much of a difference, and it ranged So it was more or less the same between dolutegravir and Derinivir. And that applied whether you were randomized to tenofovir or zadovudine. However, so that was the first question. Let's look at the second question. Remember, which was, what about if you continued tenofovir versus if you continued AZT? Same sort of idea. He has no difference, 0. Anything to the right is better for tenofovir, continuing it. Anything to the left is better to continue AZT. And you can see, although these confidence intervals here still cross 0, so we can't be sure that it's better because the true range could range anywhere along this line, there was no indication that AZT was better. You can see these dots are all on the right side, the tenofovir side of the line. And if you look at this broadly, you really don't get any hint from this trial that you needed to change to AZT. So it looked like this is at 1 year mark, you could continue tenofovir, which is really, really interesting. Because like I said, we've never done that, even though we probably should have tested this a long time ago, given what I said earlier about the fact that we know that that particular mutation for tenofovir actually does cripple the virus in the same way as 3TC cripples the virus when it gets a high level resistance mutation. So you can see here, this is so that effectively this was non-inferior. So in other words, what you could say from this, these confidence intervals did cross 0, so you couldn't be sure it was better, but you could certainly say it wasn't worse, which is really, really interesting. In other words, if you continued on tenofovir and didn't need to change off to AZT, it didn't look like you did any worse. In fact, maybe better, although it was hard to be sure of that. And interestingly, this is again a little bit of a busy slide, but if you look on the right here, again, this is looking at all these subtypes over here and all these subpopulations, and you can see the confidence interval is pretty wide. But I just wanted to show you this one thing, because you might say, well, maybe it didn't matter that you could continue tenofovir because most of those people actually didn't develop tenofovir resistance. Yeah, we're just failing first line. Maybe tenofovir was still susceptible, even though the other drugs weren't. Well, no. In fact, if you look over here, the people, for example, who had high level or intermediate level resistance to tenofovir, still this confidence interval is quite wide. But if anything, again, no hint that you needed to change to AZT, which would be if this line and the dot were all on this side, to the AZT side. So even with mutations specifically to tenofovir, you still didn't need to change, which is really, really interesting. What about safety? Because you'd say, well, okay, let's just check on that. 2 patients, I remember there's 464 people here. It's a lot of people. Only 2 of them had to change their medication. And that was due to the medication. And both of them had got anemia from AZT. 6 people had low hemoglobins and 4 of them on AZT. 2 people dropped their GFR to less than 60. They were both on tenofovir and Derinivir for what it's worth, and other adverse events were balanced. So if you look at this, these are really small numbers for 464 people. It seems safe to do either strategy, so the safety really wasn't a difference between the 2 groups. So this was the conclusion from the 1-year data from the NADIA, that dolutegravir along with NRTIs is effective as second-line therapy, and so is Derinivir, by the way, so we're more or less equally effective. But switching from tenofovir to AZT in moving to second-line therapy is not required, because remember that trial suggested, well, we couldn't be sure it was better, but it certainly didn't look worse. So it was non-inferior. Then you could say that you're really not required to switch in. Now, that was a really interesting result, which set the cat among the pigeons. Many people, though, said, well, just wait, because you've only got 1-year data. Let's see what the 2-year data shows, because sometimes, especially if you're doing something a little bit dodgy virologically, that resistance only shows itself up maybe down the line in the 2nd-year data. So most groups were deciding that this is really interesting, but we want to see 2-year data first. Now, 2-year data came out a couple of months ago only. So this is now the 96-week data, effectively 2-year data. And here's the 96-week results. And if you look over here, I've highlighted them in different ways. I'll just look at this column first. I'll talk you through this column. This is dolutegravir versus Derinivir. So again, these are 2 very good second-line options. And if you look whether you check people at viral load less than 400, less than, that should say 1,000, I beg your pardon, or less than 50 copies, dolutegravir each time had a small little advantage maybe, but it wasn't statistically significant. That confidence interval crossed the no difference mark. So in other words, they looked about the same, is the short version, between dolutegravir and Derinivir for second line. This is again people whose first line was efavirenz. Now let's look on the right-hand column. What about tenofovir versus AZT? And here we find a really interesting result. Remember I said at 1 year, you couldn't be sure it was superior. It looked like it might be, but because of that confidence interval being quite wide, we couldn't say it was superior. By 2 years, you really could. And so this is a nice way of thinking about it. It's per 1,000 people. So if you had 1,000 people who you left on tenofovir compared to those who you switched to AZT, there would be about 70 more people who suppressed if you left them on tenofovir. And the confidence interval ranges from 12 more to 128 more. In other words, tenofovir there was superior to AZT. So it wasn't even that you didn't have to switch to AZT in second line, but it was more that in fact switching to AZT was inferior, that was worse. Leaving them on tenofovir was better in this scenario. And that applied when you looked to a viral load less than 1,000 copies as well. It was also superior. And a viral load, if you made the threshold less than 50, again, this wasn't powered for that outcome, but again, this time it wasn't superior, just the confidence interval was too wide, but it was at least non-inferior. So again, overall, it looks like, because remember this first one, the less than 400 copies was the primary aim of the trial. It looks like leaving the people on tenofovir is actually better than switching them to AZT when it comes to second line therapy. And that again, that's something we haven't done in 20 years. Again, all right. And again, for what it's worth, if you look, this is again the same sort of forest plot. If you look at those, sorry, I've gone too far. If you look at the people who had tenofovir resistance at baseline, this number here, again, it favored tenofovir, although the confidence interval crossed zero. So in other words, it's non-inferior. So in other words, that applies, this applies even if you know they're resistant to tenofovir. So if you get a resistance test after first line, and reminder, we don't usually recommend that in Department of Health or HIV Clinical Society guidelines. You don't usually do resistance testing at first line, but let's say you did, and you saw it was resistant to tenofovir. This trial suggests that leaving them on tenofovir is at least as good as switching them to AZT, despite the high level resistance. And that's interesting, that's surprising. I wish we'd done this trial 10 years ago, but it's really, really good that they've done this trial now. One interesting thing, which is a little bit, remember I said that when you looked at dolutegravir versus darunavir, the point estimate, in other words, the trial showed maybe a small advantage to dolutegravir, but really not statistically significant, nothing you would want to really put any weight on. So they're probably about the same. But when you look at resistance, resistance was quite low. Only 4% of people at 2 years developed resistance, only 9 people. And that's what you'd expect because these are both very robust drugs, right? These are dolutegravir and darunavir are probably the two most robust drugs we've got. But interestingly, all of the patients who developed resistance were on dolutegravir. And of those, 3-1 tenofovir, 6-1 AZT, I don't think we should read much into that. But the dolutegravir part is interesting, and it does suggest that maybe dolutegravir is a bit less robust virologically than darunavir in second line. It's still very good. The resistance is very low at that rate, but it does suggest that maybe in second line, darunavir might even be better. And that's going to be a little bit of a tricky thing because we've still got dolutegravir as our frontline, second line drug in this scenario. It's still a very good option. And this is still quite you can see a very low number of people, only 9. It's not a lot of certainty we can derive from this, but there have been other trials which suggested something similar. And that's just something to park as an interesting thing, that we'll certainly need darunavir, even if it's not the second line drug of choice, we would still need it as a backup because there are a proportion of people who are going to get a resistance when they're on dolutegravir. Interestingly, no one on darunavir developed resistance. So what was the conclusion? Well, the first part of the conclusion, this is now at 2 years, was that dolutegravir and darunavir-based regimens maintain good viral suppression during 96 weeks. Dolutegravir is non-inferior to darunavir, but at greater risk of resistance. So I think that's a fair assumption. That's a fair conclusion from their trial. And then the key part, the most interesting part for second-line regimens, is that tenofovir should be continued in second-line therapy rather than being switched to AZT. Remember, in the first, at the 1 year mark, all they could say was there's no reason to switch because they were non-inferior. But at the 2 year mark, tenofovir is superior. In other words, they should be continued on second-line therapy on tenofovir if they were on first-line tenofovir and not switched to AZT. Now, again, that's a really, really big change. We haven't seen this for a long time. I just want to, in one slide each, just cover 2 other trials, just to show you that it's not just this one trial, because it was such a big move. It's really handy to have data from more than one source so that you can be slightly more confident that this is actually a true result. With the so-called VISENT trial, now this has not been published. It's been presented at CROI, which is a big HIV conference earlier this year. It's not yet peer-reviewed though, but I'm just showing you in really 2 slides here what it shows. They had a complicated trial design. I don't want to spend too much time on it. arm A, if you were virally, well, less than 1,000 copies, quite say suppressed, but if your viral load was low, then you could get to TLD, and this was people on TEE in the beginning. You could switch to TLD, or you could get TAF, emtricitabine dolutegravir, which is so-called TAFED. Ignore that. Really, what I want to concentrate is arm B, people who are failing on first-line therapy. And there your options were TLD or TAFED, or AZT 3TC with either Eluvia or atezanimab. So effectively, you've got 2 dolutegravir-based regimens, either with tenofovir or TAF, and 2 AZT regimens, either with Eluvia or atezanimab. So a little bit more complicated as a trial design, but just you can already start to see that you would be able to compare the AZT versus the tenofovir, although with different backbones as well. And so what did they show? Oh, sorry, going back too far again, it's jumping around. At week 48, at 1 year mark, the TLD or TAFED, so the ones that had dolutegravir and tenofovir associated together, they were superior in viral suppression at both the 1,000 copy and the 50 copy thresholds compared to boosted protease inhibitors with AZT3TC. So in other words, although here you're changing 2 things, you're changing both tenofovir and dolutegravir, and you're comparing it to AZT and a PI. When you compared them anyway, the dolutegravir and tenofovir ones did better than the AZT3TC. And now if you look at NADIA trial, we don't think it's because dolutegravir is so much better than than Eluvia or atezanimab necessarily. We think at least some of that's driven by the fact, again, that tenofovir might well be better than AZT. And again, just meant to mention this ARTIST trial on literally one slide. And that was a single arm trial, so they weren't comparing anything, but the advantage here is it's done in Cape Town, it's done in Kailicha by Graham Mankey's and group, and the people again failing a first-line efavirenz or nevirapine-based regimen with tenofovir, and they were switched to TLD, and for other reasons which are interesting, but we don't need to debate at the moment, they actually gave an extra dolutegravir dose for the first 14 days just to make sure the efavirenz wasn't messing around with it. And when they looked at that at week 24, which is about 6 months, 85% of people were suppressed. No people developed viral failure at the 1,000 mark threshold. And we're awaiting the 96-week data, which should be out in the next couple of months, at most, probably next month or so, if I'm not mistaken. But in other words, although we weren't comparing anything here, it does suggest that you can safely recycle again the tenofovir with 3TC and achieve a very high rate of virological suppression in second line. All right, so that's the data. I'm not going to spend more time on the data, but I just wanted to show you because it's really important to see where we come from. And so the principal source of this recommendation here about AZT is NADIA trial. It's supported by Vicent. It's at least it's showing supportive data, or they're not quite the same data. And ARTIST, which shows supportive data, but again, the single arm, so you can't compare. So the real key trial is NADIA, but the other 2 at least support that. There's nothing from those other 2 trials to suggest that NADIA is wrong or in need of repeating or redoing. So what now? And I hope I haven't gone too far into the weeds with that, but I do think it's really, really important to discuss and to think about. For people on TEE, and I know there's still a lot of people, unaccountably, because we really want to get people switched to TLD. We've always said if you're virally suppressed, you could switch to TLD, and that's what the DOH says, that's what the HIV Clinical Society says. But the interesting thing here now is what's new is that if you're not virally suppressed, you can still switch to TLD. So whether or not you're virally suppressed, you can switch to TLD. Why? Because we don't need to worry about resistance in terms of the first 2 drugs, in terms of the tenofovir or emtricitabine. So remember, because we can recycle tenofovir here, we can push this tenofovir and emtricitabine or tenofovir and 3TC through into the second line, and then we just change 1 drug, the efavirenz, to dolutegravir. So if you're on TE and failing, you could switch to TLD straight away. And if you're suppressed, we suggest you switch to TLD, and we have for a long time. This part's not new. And the reason we like dolutegravir overall is that it's more virologically robust for your long-term side effects. You do have to be a little bit careful in this. Some people will, if they're very well tolerating efavirenz, might have new side effects when they switch. But in general, we'd recommend switching to TLD. So again, the summary here is that for people on TEE, you can switch to TLD without doing a viral load, without worrying about resistance. You can just put them on TLD. That's a massive change, and really something that I think we encourage. We want to see people on TLD. We want to get more and more people on TLD. So if your patients are on TE, switch them, unless there's a stronger reason why not to. And again, like I said, you don't need to do this viral load. You can switch regardless of that viral load. What about people on second line now, on AZT, 3TC, and a PI? So if you suppressed on that regimen, then you can just go to TLD again. Remember that what we would have said in the past is if you suppressed on that regimen, well, you could change the PI to dolutegravir on the new 3TC AZT dolutegravir. Now we're saying, in fact, you could go backwards and give them tenofovir, even though they may have been resistant to it. So those people who are virally suppressed on second-line therapy, on AZT based with a PI, can go again straight to TLD. You don't need to worry if they're virally suppressed. You don't need to worry about that resistance to tenofovir, because, like we said, the resistance to tenofovir doesn't seem to matter between first and second line. What if you virally suppressed? If you're not virally, it should be there, not virally suppressed. What if you're not virally suppressed? We suggest that you then just continue on the same regimen for now. We are going to update the HIV Clinical Society guidelines in the next few months. It's already in the process. On this scenario, there may be something to say, but what we recommend now, and I'm sorry, it says they're virally suppressed, it should say if you're not virally suppressed, then you should just stay on that regimen temporarily, but we'll have some advice down the line. It's a little bit more complicated. Why is that more complicated? Is that because if you're failing on an AZT-based regimen, you get what's called thymidine analog mutations, TAMs, and those sometimes can mess up dolutegravir, tenofovir, in different ways, not in that standard K65R way, in a different way that might not apply to NADIA. Because remember, NADIA was a trial from first line failure to second line. Here, if you're failing second line, you have to extrapolate a bit from NADIA, and it's a little bit more risky. So we're going to put our heads together and find what we regard as the best answer there. But just to flag it and make sure everyone's aware of it, for now, just stay on that regimen. But from an HIV Clinical Society perspective, if you are suppressed on that regimen, switch to TLD. A few other wrinkles here. What about if you're failing in a Bacava containing regimen? Okay, again, so remember that's a first line regimen. What if, for example, you had renal failure and you put on a Bacava, now you're failing? Can you recycle a Bacava between first and second line, as opposed to having to switch? Because remember, we talked about tenofovir. What about a Bacava? Well, again, that's a little bit more complicated. I'm not going to offer an opinion yet. Again, we're putting our heads together. Watch this space. In the next couple of months, we'll have guidance coming out of HIV Clinician Society on this particular topic. My guess, if we had to really guess, is that probably you'll be able to stay on it as well, but we'll see. But that's an interesting point, certainly if you virally suppressed it and otherwise. But that's an interesting point. Certainly for kids, remember, if you're switching on, you could switch from a Bacava to tenofovir just as you get older and bigger. For adults, though, when you're on a Bacava, it's usually because you have renal failure, so we can't just switch to tenofovir. So again, just if you have that question, sorry, just pause, think about it for a bit. We'll get back to you soon. So in patients who are failing, again, this bottom line, and I'm going to end off soon, but in patients who are failing their regimens, and in many of the patients who aren't failing their regimens, the fundamental question really for us all to think about is this: why not TLD? So we've gone, there's most scenarios you can think of, in fact, and you could put someone on TLD from first line or in second line or in third line even, in many, many cases. And so again, I think this is a paradigm shift, because you've always had to lose the tenofovir after your first line. And now if you're able to hold it on in your first line, you can see how many, many people can get onto TLD off the first line. And so from first line, if you're on efavirenz, you could switch now regardless of viral load. If you suppressed on a PI, you could switch. Even in third line, many people would benefit from TLD. So this is going to be the next question. It's not what should you next take, it's why not. In other words, are there reasons this person shouldn't have TLD? And there will always be some, potentially. So there'll be, for example, renal failure, you can't use the tenofovir, or the patient's had a particular side effect with dolutegravir or a drug interaction or something, which might mean that you shouldn't be on it. Okay, so there will be some people who can't be on this, but a good starting point for pretty much every patient is why not TLD now? And this is, again, something we are strongly advocating for. And this really makes it, in some ways, the end of an era, I think, for AZT. It's always going to have a role, but I just wanted to show you retrospectively. This was the first drug, AZT. In 1981, we had the first reports, and perhaps probably even 1980, of some of these diseases like PJP, PCP. And really, AZT was the first drug about 1987. It had been developed for other reasons with other retroviruses in the past, and it showed to be the most promising of all the drugs they had on the cabinet, basically, for AZT. So this was the very first antiretroviral that was ever brought to market and available. And it was brought to market as monotherapy, of course, because there was only one drug at the time. So it was just AZT, and it was often given in elephant doses, really, grams a day, not milligrams a day, because it was the only drug, and people weren't sure whether how well it would maintain resistance and things like that. So really was a huge thing. And you can see the protease inhibitors as a class really only came on in 1996, a long time after that. There were some other drugs between here, but AZT was the very first. And it saved a lot of lives because many people survived on that monotherapy effectively for enough time, enough years for other drugs to be developed. And then they became dual therapy and eventually triple therapy. For those who don't know or remember the history, it was a little bit before my time, but it's a very interesting period. It really did save a lot of lives. A lot of people are alive today because of AZT. FDA actually came to the party and fast-tracked its approval in less than 4 months. So it usually takes years for them. But this was because of the public health emergency, they rushed it through in less than 4 months. And it was, at that time, it was the most expensive drug in history. It cost nearly 1,000 Rand a day in today's money. So I worked it out based on if adjusting for inflation and other things, it ends up being about 1,000 Rand a day. That's the price at the time to take this life-saving drug. And you can imagine how heartbreaking it would have been not being able to afford it at the time. Obviously, the cost is much lower now, much lower, because it's been mass-produced and many other companies have taken on the production and many other factors, but that was the cost at the time when it started. And it made the headlines here. If you look, this is the New York Times, and this is March 21st, 1987 over here. And this was the announcement of AZT, and they had this whole paper, a section in the paper about how AZT works, and here's a little diagram showing how it works. This is the US approving the drug to prolong lives of AIDS patients, cure still not achieved. Distribution will be limited because of short supply, fear of side effects, etc. So this was a huge thing. This is back in 87. This was the first big breakthrough. And so I have a soft spot for the drug in many ways. But where it is now, it's pride of place in second-line therapy, but with NADIA and others, it really doesn't seem like it's going to be that way for much longer. So probably we only use of AZT will be if both tenofovir and abacavir are contraindicated. Even then, there might be ways around it without using AZT. But for example, someone's got renal failure and gets bad side effects from abacavir or something like that, then they may not be able to do it. Like I said, there may be some wrinkles to this. There may be other things depending on if you start with abacavir, maybe. But for all intents and purposes, AZT, I think, is going to be much less use for it going on. There also are nuke-sparing regimens. For example, there's injectable regimens which just have 2 agents now, and none of which are nukes. And so with time, I think we're going to see this drug dwindle and disappear a little bit. And so I think the way to think of this really going forward for most people without contraindications is either 3TC or emtricitabine, and remember, we regard those interchangeably. So really one of them or both of them. So one of those drugs plus tenofovir plus something. I've written it without spelling. So in other words, what should you do in this scenario? You're going to start with 3TC, FTC, and tenofovir plus, for example, dolutegravir, and if that fails, then you'll probably keep these drugs on and just change the something to something like darunavir or atazanavir or something else like that. And if you're on efavirenz, you can change it straight. So in other words, we keep this as the core at the top, really across lines, so between first, second, and probably even third line. And then just add a single drug change each regimen. And that again upends some of the virology that we've been taught. We were always taught when I was studying that you couldn't change one drug in a failing regimen. Well, it looks like that's wrong. It looks like you can, especially if you have a good drug as a third drug. So I'm going to more or less end off there. I just wanted to point out there is a more detailed statement on the HIV Clinical Society website, which you can see if you go to their website and click resources and then click the guidelines tab. If the top one, the one on the 13th of May, is actually a detailed 2-page statement from what the HIV Clinician Society guidelines recommends we do in the scenario. So it's really just summarizing and expanding on some of what I've talked about tonight about reusing tenofovir between first and second line. And the reason that we brought this out even before the whole guideline had been updated was the urgency of it. It's not just, remember from NADIA, that it is non-inferior. In other words, it's not just that you can continue it, it's that you should continue it. In fact, the outcomes are better in terms of virological failure if you do continue it. So we thought that was urgent enough to warrant putting out as a statement. If you want to read more, it's available there. And I think I'm going to end, that's the statement there, the 13th of May, the use of dolutegravir-based regimens for first and second line therapy. And I'm going to pretty much end there, but I'm very happy to take questions. I do think there's some unresolved issues. One is what to do about that NADIA trial about darunavir dolutegravir second line. What's going to be best if you're on efavirenz? At the moment, the country and the world is positioned to move to dolutegravir. So I think that's probably where it is, but it does suggest that we're going to have to worry a little bit more about resistance than we initially thought with dolutegravir. And I'm just going to go back, and if you give me a second, just to go back to that original slide, because of this one is what I want to show you. That's really the conclusions which I think are the most valid, and I want you all to take home. So this is again from efavirenz. If you're on efavirenz-based first-line therapy, both dolutegravir and darunavir-based regimens maintain good suppression through to 2 years. Dolutegravir is non-inferior. In other words, either are okay, but it's at greater risk of developing resistance. And that's interesting, and I think we need to watch it. I don't want to oversell it. It's still a very small number of patients, but it does suggest that if we do move to dolutegravir fully as second line, as we are doing currently, we just need to watch out for that a little bit, at least in some people, and have a backup like darunavir. But tenofovir here should be continued in second line therapy rather than being switched to zidovudine. And that, I think, is the key takeaway of this talk. So I'm going to leave it there, and I'm very happy to take questions. Thanks very much.
Yes, thank you very much, Dr. Nel. Jeremy, that was quite empowering. Yeah, so I just want to have a small discussion with you. Then we'll take some hands, and then we'll go through some of the additional questions in the chat. So I saw that you nicely discussed, the future of AZT. What is the future of NNRTIs?
Yeah, that's such a good question, So I think less. I mean, let's put it this way. If you look at what the first world is doing at the moment, the richer countries, in other words, where money is a bit less of a problem, although increasingly less. I've actually got a person from America coming to South Africa just to get the drugs because they're so expensive in America they can't afford them. But anyway, if you look at it there, almost everyone is on an integrase inhibitor. If assuming they're not resistant. And so integrase inhibitors first line and protease inhibitors probably second line. And really the NNRTIs, the current ones at least, I think are going to be just pushed further and further down the queue in terms of where we go. There will always be some people who need them because of complicated reasons, but programmatically, if we zoom out and look at the sort of the general trends, I think they're going to be less and less important. The class though is, excuse me, sorry, is very interesting. Still got rilpivirine as a long-acting injectable agent in combination with cabotegravir, which might be interesting. There's other ones, islatravir and where I think drugs like that, which are coming and offer the potential to be, well, okay, so it's not quite an NNRTI, so I probably shouldn't have put it there, but there's other drugs in the class which with time might be useful as well. But I think the current ones we have, like efavirenz, I think the problem is they're just not robust and they have a lot of side effects with time. And again, I don't want to poo-poo it too much. I grew up on this drug in the sense that this is what I used for many years as a practitioner and for the patients. And it saved a lot of lives in this country. But I do think we just have better options at the moment.
So, yeah, I mean, it was quite interesting to see the study results. But I have this why question, because from my historic training, something doesn't make sense, right?
Sure.
You have a drug that has some level of resistance or mutations, which suddenly does better than a drug which maybe patients have not been exposed to before. Does this have to do with circulating terms, maybe which would affect AZT more than TDA?
Yeah.
There's a why question in my heart, but I don't have I understand the results, I see the results, I appreciate them, but from my own training over time, this is, now I need to take a detour. Yeah.
Yeah, and look, you're absolutely right, and I feel the same. I mean, I also feel it's quite just unnerving because it's not what I've been teaching and it's not what I've been taught. So I think if we go back, so just let me go back a little bit here to show this result here. This is if you had AZT resistance at baseline. So this is the most interesting part. Well, sorry, not the most interesting, but it kind of answers some of the questions. If you had TAMs, again, the tenofovir did better. But if you didn't have TAMs, it still did better. So it's very, it's very odd in some ways. I think part of the answer is what we started with, that we know, and we've probably not appreciated how much activity is retained in the face of so-called high-level resistance. Probably that high-level resistance is not the right word. It probably should at most be intermediate-level resistance or something, because we know a bit like the M184V for lamivudine, that K65R for tenofovir, really, you do get a lot of activity still. A half a log is about 2/3 reduction. So if you, again, if you have a million of viral load of, let's say 100,000, if you just use monotherapy, that drug, you get it down to 30,000. So it's still got a lot of activity. I think partly that's the answer, but I think that is the key question. You're absolutely right. It's trying to understand mechanistically what's going on. One other option is that perhaps the AZT is just a bit less tolerable, and so people are more likely to default it because they didn't do, for example, drug levels here. It would be really nice to know that. And then the third option, I think, is something that we're not expecting. Like, for example, maybe we understand less about resistance than we thought. And once you start adding 3 or 4 drugs together with complicated resistance patterns, it just does something different. And I think that's really important when it comes to Vacavir, because if this is driven by the K65R mutation, for example, like, what happens if you get a TAM and the TAM knocks out tenofovir? Could you extrapolate then? And not obviously. And so I agree with you. It's a really big question that I would love to have answered, and I share your anxiety about it. I agree. It would be really nice. Yeah.
Yeah, on the issue you've just mentioned around the tolerability and AZT, how was because there was a question from someone talking about what was the loss to follow up in the trial, and particularly in the AZT, maybe, I'm not sure.
Yeah, so I don't have the loss to follow-up numbers on me, but this is useful for here. So the trial, it was relatively well tolerated, to be honest. The 2 people stopped because of the anemia from AZT only, but remember, there's 200 people in each of these arms. And 6 people had low hemoglobins, and 4 of them were on AZT. So in other words, that was probably driving the low hemoglobins in those cases. The trial population, though, is relatively, it's never the best to look at this sort of thing because they tend to be the most healthy, robust people. You're not always taking the sick patients who might have more side effects on some of these drugs. But I think it's fair to say, look, there wasn't a big difference between AZT and tenofovir in this trial. So although from other trials, it seems that AZT is less well tolerated than tenofovir, in this particular trial, they looked about the same, which was interesting.
All right, yeah. So before I take hands, I just want then to your understanding of the upcoming guidelines. Are we looking at something, simple, better, or are we looking at a lot of if this do that, if this do that? What do you foresee as the ultimate outcome? Yeah,
it's a good question. So, and it's a really good thing for anyone who writes a guideline to try and remember, is that people don't have time to make this too complicated and weed through this. So I agree with you, it needs to be as simple as possible. We certainly will try to make it simple. I'm one member of a large committee, but I think that that's well taken, and I think a lot of it becomes simpler. So like we said, if you start from the point of view of start with tenofovir and 3TC or FTC, and then try and find a third drug on that, and then switch between first, second, and third lines on that basis, I think that's pretty simple, and that it offers a simplification. I do think, though, there will be some of those edge cases where it's a little bit less complicated, so a little bit more complicated. What if you can't use tenofovir, for example, or what if they've got a TAM to tenofovir, or what? So I think there are complications which are going to come, but I do think overall this is a simplification because you do get to reuse tenofovir and therefore 3TC as well through or emtricitabine through multiple lines. So you've really, like I said, you've got those key drugs. We always did that with 3TC. We always banked on 3TC in each line or FTC. And then you could just add 2 drugs to it. Well, now you can bank on 2 of those drugs and just add 1 drug to it, which makes it simpler. But there will always be complications in individual cases, yeah.
Superb. Let's take 2 hands, and then we will try and zoom into some of the questions in the Q&A. Santos Zinga, you may unmute. Thank you.
Yeah, okay. Thank you very much for this information. It was very, very important. I just want to say about, because I'm working in in the clinics treating HIV patients. Yeah, just last, I think last month, the nurse just told me, because there was a patient who was on TEE, was not virological suppressed. The viral load was million, something like this. And mistakenly, the nurse told me they put that patient on TLD without knowing that you cannot change a patient from TEE to TLD if the viral load is more than 1,000. But mistakenly, the nurse told me that that patient was put in TLD, and she brought also the result, the viral load of that patient, the former and the new viral load. So that patient, after being put into TLD, after 2 months, patient was suppressed completely. The viral load was suppressed completely on TLD. So now, as the nurse was telling me, if what we can do, I said, okay, we can just continue TLD since the patient is suppressed. So this is the information I just want to say. So it's very, very important what I've learned here now. So yeah, thank you very much for this information.
Thank you, Doc. Let's take the second hand first, Jeremy, and then you will comment. Craig, you may unmute.
Yeah, thank you very much for the presentation, Dr. Jeremy. Very informative. I hope I'm gonna structure my question in a way I thought. But my question is related to, NADIA trial addressing when it comes to tenofovir. And my question is, you have a client who's on TEE, and then he's not virologically suppressed, and then assumingly so, he develops resistance to tenofovir. Then you change to TLD as Nadia suggested. Then along the way, the patient develops renal failure. Then you want to switch to abacavir, but we know that in terms of the cross resistance of tenofovir and abacavir, wouldn't this affect in terms of its second line thing, because we never did with abacavir? Wouldn't this affect it going forward? Thank you.
Yeah, a bit. I'm hoping Jeremy got that. Jeremy.
Yes, yeah, thank you. So for the first speaker, so I agree that it's nice, as you said, to see that it did work in that scenario. And I think that's where it's empowering. And just again, to be clear, I know that many people on the call are still working with Department of Health guidelines. They haven't yet changed. I'm just showing how they're likely to change. But I understand that you may need to stick with the DOH guidelines for now. I'm just showing you what we think will change and what the HIV Clinical Society do. But I agree, it's nice to see that they do suppress on those patients, and this is what the trial showed. Second question is very hard, because you asked one of the questions which we don't yet have a good answer for. So you're absolutely right. So you could continue to tenofovir through to the second line. What about, could I then switch to abacavir? And that's hard. And that's unfortunately one of those questions which is going to be debated in the next month or so and then come out of the guidelines. I don't want to give a definitive answer yet, because put it this way, this NADIA trial doesn't answer that question. So we would have to extrapolate from others. I do think, though, if the person is suppressed on average, you can usually get away with taking a bit of a chance virologically. So, because they're already suppressed, it's easy to keep people suppressed if they're suppressed. People who are failing already, like their viral load now on that tenofovir, when you need to switch for renal failure reasons, but their viral load is now many, many thousands, that's a bit trickier and a bit more dangerous. I'm not saying it's wrong. I'm just saying I don't think we know yet. So I think watch the space. I'm aware that's not a great answer for you, and I'm sorry I can't give it tonight, but I don't want to tell you one thing and in 2 months' time it's a different message coming out. These are coming. These are the sort of things we're going to debate, these kind of edge cases, like Lesejo said, where in some ways it's simpler, but what about these more complicated scenarios? In the past, we would have recommended changing to AZT, so we know that's safe. But we do also know that many people with renal failure have anemia too. And so in many cases, you're kind of stuck and you end up on abacavir by default anyway, in which case there's nothing you can do, whether it's good or bad. It's the only option you've got. But we will try and answer that in more detail coming up. But thanks, it's a great question and very, very difficult to answer from NADIA, because they didn't test that particular scenario.
Great. And we will take your hand shortly. Jeremy, I've had, I see there's questions about this, but I've also, even today, I got a call about patients who are fully suppressed on TEE, who are transitioned to TLD, and they suddenly present with this low, not necessarily low level, viral load of 1,800. And today's case was even at about, the repeat was even at 2,000. I'm not sure. I saw something on one of your slides where, the Cape Town study, maybe they're trying to counter the effect of, if that is the reason, but I'm not sure if you have received calls like that and what's your understanding of, I could only advise clinicians to report through pharmacovigilance so that, can pick up these cases. But from a theory point of view, I can't make sense of why that would happen.
Yeah. So I suspect, at least in some cases, what's happening is something like this. If people are on TEE, let's put it this way, if you start people on TEE and you start people on TLD, we know that on average people tolerate TLD better with dolutegravir, in other words, than efavirenz. We know this. But if you're on TEE already and you're tolerating it very well, and then you start sort of changing them to tenofovir-based regimens, as we suggest you do, and I agree you should on average, but you're taking people who have no side effects because they're tolerating it well, and then you're giving them a new drug. And there's always a chance that some of them will develop a new side effect related to the dolutegravir. So there's something, I do think we should be encouraging people to switch to TLD, but it is something just to tell your patients that if they develop, we're changing one drug, if you develop new side effects, just let us know and we'll help that. Because I think what happens sometimes is people do develop those new side effects and then they stop taking the drug, or at least they don't take it as much. That's probably the answer in most cases. And obviously, we also know with time, people just get worse at taking medicines anyway in many cases. So there is a time component to this. If you'd left them on TE, some of them would have had the same issue. I don't think there's a good reason theoretically to worry that the change to dolutegravir should make it worse. In fact, it should make it better. But I do think, and there's no problem reporting it, of course, because it's important to get those reports. But I think one thing, at least as a starting point, is just to ask the patient in quite a lot of detail, are you sure you're not having any new side effects since changing these medicines? Because that can be one reason. I'm not saying it's the only reason, but it can be one reason.
Great. We have a number of questions, so I'm trying to cover them as themes. There is a number of questions around the protease inhibitors, Duranavir. What's your take about the future of protease inhibitors? Because you said, basically, it's a question about, so what would the second line look like, in the future? Yeah, sure. Someone is talking about the cost of Duranavir and so on. So maybe you can just answer that. Yeah, thanks.
Sure. And I think that's a good question. Protease inhibitors, I think, at least for the medium term, are always going to have a place because we need something that's not dolutegravir. And for people who are intolerant of it or who fail it or something like that. So like we said, we're going to see resistance to dolutegravir. We're already seeing some cases popping up here or there around the country. And with time, of course, the longer the population's on the drug, the more likely they are to fail it. So you need a second line. So we're assuming dolutegravir is going to be first line, at least for the foreseeable future. So then you need a second line drug instead. And the second line of choice would be at the moment a protease inhibitor. And then it's just a choice between the three main options that we've got. We've got Eluvia, which is lopinavir, we've got atazanavir, we've got durinavir, each of them with ritonavir. Each of them now co-formulated with ritonavir, which helps because before it was only Eluvia that was co-formulated. You can now get the new tenders just come out, within the next few months. Department of Health will have those as co-formulated options, which is nice. And then it's really just a comparison between the three drugs. We do have a preference in the HIV Clinician Society guidelines for this. Our first choice is durinavir, second choice atazanavir, third choice Eluvia. And that's based partly on side effects and factors around that. Durinavir is a great drug, and you can see it's probably more robust than atazanavir. But the issue has been in the past price, and we're aware of that, and that's one reason why Department of Health is probably going to go to atazanavir more than Eluvia as its PI of choice, because it's just in terms of cost. Eluvia is a very robust drug. It's again saved a lot of lives. It is less well tolerated though than the other two. And atazanavir is again a nice option. Our second choice. A little bit, a lot of people end up with that unconjugated hyperbilirubinemia, which is very distressing to them, even though it's very safe. And it's a bit less robust than Darunavir, but I think in the end, that's probably what Department of Health will go to as a second line PI. So I think PIs are still going to be used, but as second to Darunavir choice, so second to dolutegravir choices. But we're going to need them, of course. There's no way we're going to get away with one option only. And I think there will still be many people on those drugs for quite a long time, and they are good drugs. I mean, they work well. But we want as many people as possible to be on this sort of TLD regimen, if possible, because again of cost reasons and of simplification reasons and other factors like that.
So Dr. Nel, tell me, never switch a single drug because I see a lot of comments. People are saying, but how can that be? Somebody saying, how am I going to convince doctors and nurses when the teacher himself, Dr. Mawela, used to be so loud about it? But my real question to you is that, in your understanding, does this rule fall away, or there's gonna be context under which it's still applicable?
Well, I think we can be definitive that it does fall away now for tenofovir specifically. Whether it applies to other drugs, I would be much more cautious of. So I certainly don't think we should throw away that rule. But I do think with tenofovir specifically, we can throw away that rule. If you're using tenofovir, recycling it is fine. And I agree with you. For years, I've been teaching that. I've been taught that was the dogma. But I think that we must change with evidence. So the evidence here is good that you can reuse it, and I think we should. But I do caution that we mustn't just therefore have the idea that you can recycle anything. No, I think we have good evidence you can recycle 3TC or emtricitabine, and you have good evidence you can recycle tenofovir now. But it's not necessarily true of other drugs like AZT and abacavir and other options. So I think that rule still holds for other combinations. But for tenofovir, I think we're okay. I think the evidence is good that you can reuse it.
All right. There's a lot of questions about the guidelines and when you think. So from the society side, I think I've heard you that it's work in progress in the next month or two. I don't know on the DOH side if you have some ideas whether the process has started or not. Yeah, I
don't offhand. I mean, I know in the background, just through the grapevine, they're working on the same question, but I don't know. I'm not part of that group in terms of when they'll bring it out. But I mean, I think you can rest assured that probably both groups will have something out in let's say 3 to 4 months. I mean, as a rough guess, it may be even sooner with DOH because they've been working on it for a while. I'm not sure, but I think again it's something that's coming in the near future. I'm not entirely sure about the dates. I can't give you more specificity than that, but it's coming, which is why I think it's a good topic to start thinking about.
All right, colleagues, we are almost getting to the end. We still have 2 more minutes before 7. I'm not answering each question as it comes, but I'm looking at themes. There's also a theme, Dr. Nel, around the DTG, and I think there's like 2 or 3 questions looking at DTG and metformin. I know it's not necessarily covered here, but we do get a lot of calls around that. Whether do you avoid a DTG when patients are on metformin, or do you adjust the diabetic treatment? I don't know what has been your experience in that. Yeah, sure.
Yeah, so it's not contraindicated. You just have to be careful of the dosing. So what dolutegravir does is it pushes up the level of metformin. So it's not a problem with the ARVs. The ARVs will work fine with metformin. The problem is the other way around. You effectively increase the body's exposure to the metformin. So what we suggest is that you don't give metformin more than 1 gram in total a day, which really means if you're giving metformin twice a day, 500 milligrams twice a day is the maximum dose. And then for that, you get something like the equivalent of about 850 milligrams of metformin. It's as if you're giving 850, but you're only giving 500. So it's not a problem. You can use it. You just have to be careful not to overdose on the metformin because the level will be pushed up with dolutegravir.
Superb. Piso is asking, what is the reason for adding extra DTG for 14 days? I have an idea. I'm not sure if you want to comment on that.
So it's been studied by the Cape Town crew of, for example, Gary Martins and Graham Mankison are really, really good at many things in HIV, but one of them is this pharmacology part. And in theory, efavirenz decreases the dolutegravir level a little bit. And just for a while until the efavirenz wears off. So they were studying whether it would help to give another dolutegravir dose for those 14 days. I do want to emphasize, though, it's theoretical. We don't know whether that makes any difference clinically, which is the reason they're studying it, right? So I don't think you need to do that now, but it's something that I think I'm grateful that they're looking at, just to double check that it's fine just to switch straight away. Or do we need maybe for the first bit to increase the dolutegravir? I don't think you need to do it in clinical practice, at least until there's evidence from this group or others that there's any danger to it. So that's the reason they did it, but I don't think I would necessarily follow practice now unless there's a signal that it's harmful.
All right, monotherapy, dual therapy, triple therapy, because someone is asking about 3TC monotherapy. There's also questions around 2 drugs versus 3 drugs. Or is 2 drugs the future, or what's your take? Yeah,
so monotherapy, certainly not. Unfortunately, we've never won with monotherapy. One day we will. I think we'll get the ultimate drug, which is just so robust that you can give it as monotherapy. But for now, even with robust drugs like dolutegravir, monotherapy doesn't work. 3TC people have tried in the past, especially with pediatrics. Not a fan of that at all. I don't think anyone should be on monotherapy. I think you're just kidding yourself. So rather, it has to be a full regimen. Now, there are some evidence for particular combinations. There's 3TC and dolutegravir in first line as a dual therapy. There's rilpivirine and dolutegravir in second line as dual therapy. And of course, there's injectables, which are, rilpivirine and cabotegravir as those. Now, you just have to be careful with that. They are fine in the right scenarios. You just have to make sure the scenario is right. So, for example, and we do have this a little bit in the HIV Clinical Society guidelines, if you're on 3TC dolutegravir and you want to give that as your first line drug, firstly, make sure it's first line, not second line or third line. Secondly, the viral load can't be more than 500,000. The CD4 can't be less than 200. They can't have hepatitis B. They can't be on TB treatment, like rifampicin. So there's a number of issues that you have to consider. So that's why it's not, I don't think, ever going to be frontline as a standard option, but it's an alternative, that particular frontline therapy, if you fulfill certain criteria which are itemized in the HIV Clinical Society guidelines. So there definitely are 2 drug regimens which are fine, and we can do it. I think that for now, most of the guidance will still be around 3 drugs because it's simpler in many senses, and especially if you can reuse good drugs like tenofovir. But I think it is important to at least be aware of those 2 drug options for particular cases if the scenario fits. Yeah.
Nice. I think we're gonna close with this. I'm not sure how you're going to respond because these questions are more asking around what these results mean, particularly for PEDS. I saw Dr. Leon was in the group. I don't know if he wants to make a comment, but Jeremy, it's clear for adults, you know what it means. For children and pregnant women, any special things to think
pregnant
about?
Pregnant women, I think is fine. We don't have any worries, especially remember about dolutegravir anymore. We're okay with it. Peds, I certainly wouldn't want to speak on their behalf because I don't see any pediatric patients of my own. The pediatricians were part of the group who wrote the guideline, that statement on the HIV Clinical Society guideline, and I think may well be more aggressive about the Abacavir issue, because the difference is that, in pediatrics, Abacavir transition to tenofovir is often just for weight reasons, whereas in adults, it's very difficult. If you're on Abacavir, it's usually because you can't have tenofovir. But I do think it will be very similar. But if there's anyone on who wants to chip in for peds side, I'd be very happy because I don't feel qualified to give a pediatric opinion. I'm afraid.
Yeah, I've asked Dr. Leon, I've given him, Dr. Leon, maybe just give your overall sense of the topic and maybe specific things around kids. Thank you.
Yeah, thanks. Now, look, I think in terms of patients who are on the back of a 3TC and efavirenz or even lepinolizumab who've been failing, since the 2019 guidelines, we've been transitioning those patients to TLD if they're above 35 kilos in 10 years, providing that. They will transition even if they're failing, and it's based on studies looking at the incidence of K65R or resistance to tenofovir in patients failing Abacavir, which were very low. So we don't have an issue with that. Our issue is, and I'd like to ask Jeremy, is if you've got a patient who is on Abacavir 3TC and efavirenz or on Abacavir 3TC and lepinolizumab, a pediatric patient who's failing it now, and we want to transition to dolutegravir, can we stick with the Abacavir 3TC backbone because from what I can understand is that NADIA is not talking about that as well. And our feeling is we can't extrapolate from tenofovir to abacavir. In other words, if you changing to tenofovir is very different to changing to abacavir. Maybe Jeremy could comment on that.
Yeah, I agree, Leon, and thanks very much for those comments. And I agree, and that's why I kind of punted for touch a little bit in this and said, look, we will address that certainly from an adult side, from what we'd recommend in an adult scenario soon. But I agree with you, and I do think again that's what Dr. Levine says is a really good point just to take home, is that NADIA was a trial from people failing first-line drugs, which included tenofovir and an NNRTI like efavirenz. It's very difficult to extrapolate to other drugs, and like abacavir, for example, and we agree with that totally because the mechanism may not be the same, and it's very difficult to extrapolate when you're failing in complicated resistance patterns as well. In many cases, you might get away with it, but I don't know, and so that's something I agree. You can't just extrapolate straight, and it's something we're going to have to look at and hopefully provide guidance for those cases. I don't have a good answer yet, I'm afraid. It's something I think hopefully will come out in the next couple of months.
Superb. Dr. Leon, your closing remarks as I give Dr. Nel closing remarks.
Well, I haven't done anything tonight, so, but yeah, just to say that this is fantastic. We've welcomed it. It's going to make a major difference to our patients, and we'd really like to see an interim guidance coming out in the DOH, just like the Clinician Society has done in the meantime while they're waiting for their definitive guidelines to come out. We really like to see an interim guidance for the DOH saying the same thing so that we can go and start changing our patients in the meantime while we're waiting for the definitive guidelines. Thank you.
Superb. Thank you. Thank you very much. Dr. Jeremy, I know you have put the slide as your closing.
Yes, well, I was going to say this is the slide I think to take home at the moment. So I agree very much with Dr. Levine. So I hope that the DOH will change soon to make this all align. But just to be aware for those who are following DOH, what might well be coming down the line soon. And just to be aware of the rationale that, the fact that you can reuse this tenofovir across lines is really a big breakthrough. And again, it's a cheaper drug for patients who have to buy it, and for the Department of Health, it's better tolerated in many senses. It's once a day, not twice a day, like AZT normally is. The monitoring in terms of hemoglobin falls away, so this really has a lot of advantages. And of course, the biggest one is that the viral load suppression is better apparently with maintaining that tenofovir on. So I do think this is a big change, and there are some complications which we've talked about from other scenarios and coming from different angles, which we're going to have to work through. But the part that's on this slide, I think we can be pretty confident on, and hopefully we can change it across the board pretty soon.